Okay, so hello everyone, and welcome to this webinar or chat. I'm Stéphanie Thibault-Gagnon, and I'm joined today by Gráinne Donnelly. And so I'm not really sure what to call this today, a webinar or a chat, because really this is just a conversation between Gráinne and I. We wanted to just have a chance to talk about a topic that we're both passionate about, which is returning to running postpartum. And we just thought it'd be interesting to record our chat, and in that way we can share it with anyone who's interested in viewing this. Well, basically, we're going to go through how we work with women, how we actually guide them in our clinical practice in returning to running or starting running postpartum, so after having a baby. So for those of you who don't know me, I'm a pelvic health physiotherapist in Montreal, Canada. So if you hear a little bit of an accent, it's because I'm French Canadian. And so I've been practicing for 15 years as a clinical physical therapist. And I'm also, I consider myself a researcher, so I dabble in research. I obtained my PhD in 2019 from Queen's University. My research work focused mainly on pelvic floor muscle dysfunction in women with genital pelvic pain. And I used ultrasound imaging in my research to be able to study the pelvic floor muscles in this population. And so now I work mostly in clinical practice. I still continue to be involved in research with different research groups. I'm a bit addicted to reading research articles, and actually Gráinne and I will talk a little bit more about how we met in a moment, but basically that's how it started. And so and I also teach. So one of the courses that I teach is the female runner course. It's a course that's offered through the running clinic. So it's a 2-day course that was developed by myself and an international team of clinicians and researchers and runners. And it's a course that's really evidence-based. So we really wanted to use the most updated evidence on running and on female health and pelvic health. And so now it's become a 2-day course. It started off as a 1-day course. It's now a 2-day course. It's been offered in about, I don't remember how many countries. So France, Belgium, Italy, in Canada. It's currently offered in French, and this year we'll be launching the English course. And so it will be at the end, in the description below this video, I'll be including links, and you'll be able to sign up to the newsletter if you'd like to find out more about the course. And I'll be talking a little bit about the course later on. And I think that's what I wanted to say for myself. So I'm so happy to be joined by Gráinne. We had many chats since we've met. Gráinne is someone who I absolutely adore and admire. I think she's a superstar. I think she's a super physio, super researcher, super mom. And I'm just so happy that we're getting a chance to talk today and to be able to share one of these conversations that we often have. And so I'll let Gráinne introduce herself, and then we can even talk a little bit, or maybe she'll want to talk about how we met, how we came to come about.
Oh, thanks, Stephanie. I'm so delighted we're here, and I'm so delighted we're pressing record, because we often have conversations and afterwards we're like, oh, that was so good, like we covered so much, and yeah, we just go everywhere. So I'm a pelvic health physiotherapist as well, based in Northern Ireland, which is actually part of the UK. That often gets confusing. So I'm in Ireland, but Northern Ireland. And I have been qualified and in clinical practice for coming up to 15 years too, actually. And I would call myself, I'm delving deeper and deeper into the world of research and academia. So I would call myself a bit of a clinical researcher, but I don't have my PhD yet. I might go down that direction at some stage. But I also teach as well, and so I'm involved in some master modules in different universities. I guest lecture, and I also teach some courses on diastasis rectus abdominis. I also teach clinicians on ultrasound imaging, and we recently have a athletic female course, which is an online course that we'll put in the show notes too. So again, to echo what you're saying, we've so many common grounds, I feel, between ultrasound and our passions for postpartum exercise and teaching, and the fact that we're striving for evidence-based and top quality education so that we can really inform and help health and fitness professionals around the world with their clinical reasoning, and that's what it all is. I don't want people to learn off recipes or anything. I want them getting the tools to be able to think for themselves about the individual they have in front of them. So a couple of years ago, how I started my, I suppose, journey towards a little bit of research was I linked in with Emma Brockwell and Tom Goom, who are both physiotherapists from the UK. Emma's a fellow pelvic health physiotherapist. Tom's a musculoskeletal sports physiotherapist. And we realised that there was no guidance or guidelines or any sort of frameworks for return to sport postpartum. There was return to sport post-injury, but not postpartum. So we decided to, I suppose, do a bit of a scoping review and put out a white paper as such on return to running postpartum. We started to delve into the research. We found out that there wasn't a lot out there on postpartum women or women in general. And so a lot of it was extrapolated and expert consensus. And we put that out there, probably thinking that people near us would maybe look at it. We didn't know if it would be useful or not, but it got a good bit of traction. And you came across it, Stephanie, and you had a lot of questions. So I got an email one time and I was like, oh boy, she knows what she's talking about. Because what I will say is that it's quite, I don't know how you feel now that you're a bit more seasoned as a researcher, but that was my first sort of step into it. And it's quite a vulnerable place to be there, to do some work. So you're doing the best work you can. You're looking at the research, you're critiquing, you're trying to take what you can from it accurately, you know, and not have any bias in it. And you're putting that out there. It can be a bit vulnerable into how it's received, because you don't want people to think this is poor work, or this is no good, or this is not what that says. So, but you sent me a lovely email, and that's what started our journey. So I'll let you take over and discuss how we met.
Exactly. So thanks, Gráinne, for sort of, talking about yourself, introducing yourself, and introducing sort of how we met. On my end, so we met about almost 2 years ago. So it was the start of the pandemic. So it was early to 2020. And I had just finished my PhD in 2019, and one of the topics that I was really interested in following my PhD was running and its effects on pelvic health. So I'm a recreational runner myself. I follow a lot of women who are runners. And I was wondering if what we were teaching in clinic and how we were guiding women was actually appropriate, and if it was actually founded in research and in evidence. So I wasn't able to really, I hadn't any sort of information that confirmed that. So I started searching the literature, thinking, okay, I'm going to find some articles that are going to come and, back up what I'm doing, the timelines that I'm saying. At that time, we had a lot of people, you would hear people telling women, you need to wait 3 months, 6 months, 12 months before starting to run. Or you also had people saying, oh, after your 6 weeks, you're good to go. You can just get back to whatever you were doing before. So whether you were a marathon runner, an ultra distance runner, whether you were a weightlifter, basically that 6 weeks was sort of the criteria. A lot of doctors were just saying, okay, 6 weeks, you're good to go. And so I was questioning myself. I was doubting myself. I'm always doing that. So I find that after 15 years of practice, I actually question myself even more than I used to when I first started. When you first start, you're like, okay, I've learned everything I need to learn in school. Here you go. And then you realize very quickly on that that's not how it works. So as I was searching, I wasn't finding much, but I found this amazing guideline written by yourself, by Tom Goon, and by Emma Brockwell. And I was like, oh my goodness, this is amazing. They did all the work that I had this paper that basically highlighted, the research that had been done so far, basically where the gaps in knowledge were. And so we know that there's actually more gaps in knowledge than there is research evidence right now supporting, running, its effects on pelvic health. And so I was so excited. So I read and reread the guidelines, and I wrote a bunch of notes and a bunch of questions, because I was like, okay, where did they get that from? And because a lot of it had to be based on, you guys did such a fantastic job. And it was amazing that you put it out there, open access, accessible to everyone. Because at the time I had finished my PhD, so I did not have any access to
I know, and that's one of my biggest pet peeves. It's the barriers. Like, we want people to know evidence-based practice, but then we put all these fences and doors in place where they can't access it, and you're like, well, like,
Yeah, and then we complain that, knowledge translation is slow, that once, there's evidence of something, it takes a long time for it to be integrated into clinical practice. But it's just the way the setup is. The information is not, it's getting better. I find there are more and more open access articles. There are, a lot of, there are some research databases, Pedro for physiotherapy. There's different ways of accessing the research, but still, it's still not highly accessible to clinicians. So just going back to the fact that I thought it was absolutely fantastic that your guidelines were out in the public domain, and that's it. You did a great job, and you did the best job that you could do with the information that was out there at the time. You took whatever research evidence there was, realized that most of what we were doing or what we were saying was based on clinical opinion, expert opinion, and
guys, men, like it was based on
men.
Yeah, men.
Yes, exactly. And then kind of just summed it up and then provided, the best guidelines that you could with the information that was out there at the time. And we have to say that 2-3 years later, we have more, but we're still not, there's still a lot of gaps in knowledge right now. And I think that guideline was great because it shed light onto, running and, women and running and pelvic health and running postpartum and in the perinatal. I think it was really the beginning of something that I think is just going to continue to grow. And so, yes, congrats.
Thank you.
Yes. And I remember sending that email. I sent it to yourself. I sent it to Tom Boone and Emma Brockwell. I put you all in CC. And then I get this email back from Gráinne saying, are you a researcher?
I was like, she needs to know what she's asking proper questions here.
And so I remember just us deciding to set up sort of a conversation just like this to talk a little bit more into it. And it was kind of, we just kind of clicked. And you were just so generous with your responses and your time, as you always are. I don't understand. It looks like there's more than 24 hours in your day.
There's not, believe me, there is not. Hence why I actually, before we jumped on this, I was like, I just literally ran from finishing work, did a quick workout and come back, because I always feel like I'm squeezing everything in, but that's just my life at the minute. That's okay.
And it's great that we're talking about this, because this is the reality. We're going to be talking about women who want to get back to running or start running postpartum and kind of get back to their physical activity. And I mean, you're the perfect example. You've been through it 4 times?
Yeah,
exactly.
4 times.
So I'm not lucky enough yet to have had the chance of having children, but I do work with a lot of women. So I live vicariously through them, and I really empathize with them as well. So, so that just adds to also all of your knowledge and everything that you have to share with everyone. So that's fantastic. So it's a little bit about how we met, and then it's been about 2 years. So we've had several conversations since then. I mean, through messaging and Zooms, and we haven't met in person yet, but I feel like I've met you in person.
I know, it's mad, isn't it? It's like, it's how small the world can become. And it's like, I was saying to Stephanie beforehand, you have such an amazing understanding of literature and research and stuff, and that I'm really inspired by that, because I love all that, and I'm trying to, I'm constantly learning more and more about research and academia, and I'm like, oh, I'd love to transplant your brain into me, because you're so good. And I love how much you can discuss, and you're not afraid to, because even recently when we were talking about the athletic female course, which you're a guest speaker on, the athletic female course, and you were able to even discuss maybe some of the ways that I'm interpreting research, and we discussed papers and stuff, and I love that. And I'm like, that's so interesting, because that's how we all develop and get better, because we have to be able to understand what exactly a paper is telling us and what it's not telling us.
Exactly. Absolutely. And that I think that's the theme also for research in general. We need to understand what the research in general has told us so far, not just the research, our clinical, like, we're not throwing out expert opinion and clinical experience. It's really important. I still, to this day, I base myself a lot on my clinical experience. And, the more you have, the more you're able to do that. But we do need to be honest with the evidence that we do have. And when we make clear statements, we need to be honest about where those statements are coming from. Are they coming from this, evidence that we've gathered through research, or are they our opinion, or a consensus amongst clinicians? So there's worth to it, but we just have to be honest about where that's coming from, because there's a lot of, we want to inform and we don't want to misinform, right? Before we do good, we need to not do harm.
Yeah.
And then we also want to, in general, by informing and translating knowledge, we're empowering, we're reassuring, we're reducing fear, we're encouraging people to, we'll delve a little bit more into running and physical activity, but we're encouraging them to stay active and not over limiting based on myths or, beliefs that we have that are not founded in research. So that's just sort of a little bit of my thought process. What did I want to say now? I think we talked about, so basically why we're having this chat today. What we're going to do is kind of walk through together, Gráinne and I, how we work with women, how we guide them in beginning or returning to running postpartum. We now have more research, thanks in large part to Gráinne and the people that she's worked with on returning to running postpartum. So we'll be able to highlight some of Gráinne's work through our talk and how that's actually influencing our work now. So the aim really is to be able to offer some information, not only for health and fitness professionals, but also for anyone watching who might want to start or return to running. So we want to make this sort of a bit of that's why we called it a chat, because we're trying to inform, but sort of in an informal way, just by talking and walking through sort of our process. Did you want to add anything before I start with my questions, Gráinne?
No, I think you've set us up really, really well, and I think I'm excited to get stuck in.
Yeah, let's do it.
I say that now. If you ask me a hard question, I'll feel it back to you.
That's fine. I'm prepared. So let's see. Yeah. So I thought that we could start off. I kind of gave it away just a moment ago, but I thought we should start off by, by two main questions. I wanted to talk about the time scales. So when we talk about returning to running postpartum, we often get the question, how long do I have to wait? And I talk about how, some people will say you have to wait 3 months, 6 months, 12 months. Some people will say, well, 6 weeks, you're good to go. And so is there actually, so this is my first question, and I'll lead it up with a second question. Is there an actual timeline? Is there an actual time point where we can just start running and it's okay? So that's my first question. And then my second question is, and it links back to one of the things that we get asked very often is running bad for pelvic health, for the pelvic floor? Does it cause urinary incontinence and pelvic organ prolapses? So I'm not even sure I should have linked them up, but they were the two, I thought these were two, I don't know if you would agree, but two of the questions that I get most often clinically, or they're questions, but also they're beliefs. So let's start like that. So let's start with the timeline. Is there a time that you can say, okay, this is the time when I can start running again after having a baby?
So this is the million dollar question. This is one I get a lot. And this is also one that we get asked a lot since putting that white paper out, actually, because within it, we did a scope and review of the literature. And like we've already alluded to, there is and was very little research studying postpartum women and doing studies specific to running and getting back to exercise. And there was a lack of studies on women in general. So a lot of our research and understanding is taken from studies involving male populations. So, and we know the more we understand science, we know that there's differences, physical, physiological, psychological differences between males and females. So that's our first hurdle. But when we looked at tissue healing and what we understand about the principles of tissue healing, whether that's abdominal tissue healing, whether that's perineal or vaginal tissue healing, we find that on average, there's signs of ongoing healing beyond 4 months, basically. And so from that there, we find that on average, the average woman's probably going to be in around 12 weeks when it's appropriate. But everyone's so individual. So for some women, they're going to be ready much sooner. For some women, 12 weeks isn't going to be enough. And I think it's sensible when we think of the 6-week timescale that often gets put out there, because there's often a myth that you do nothing for 6 weeks and then suddenly you wake up in 6 week day and you do everything because you're automatically recovered. And if we put it in the context of injury or sports recovery or off season, like any sort of training that we do, once we take a period of relative downtime and are not training, there's deconditioning that occurs. And that's the same principle can be applied to pregnancy, because we do move differently towards the end of pregnancy. We exert ourselves less. So even if you're someone who exercised right the way through your pregnancy, you're going to have reconditioning needs afterwards. So I think it's sensible when we consider reconditioning needs and tissue healing that you're going to be at least 6 weeks before you're ready to think about impact training. But it's very individual from there, because it really depends on your delivery, your pregnancy, how things are going afterwards, because as we know, there's so many other factors that feed into readiness. It's not just all about the physical tissue healing. There's also things like how much sleep you're getting, how much support you have at home, energy levels, medical baseline. There's a lot of factors that feed in, so it's very, very individual. Would you agree with that, Stephanie?
I would absolutely agree with that. But I mean, we gave it away. There really is no specific time point. And time is really not the only factor to consider. There are just so many other factors, and I think I'm taking these words from one of your papers, but really the whole system approach. And so that's really what you were talking about just in a moment, and sort of all the different biopsychosocial factors. And when we talk about time points, there are time points. We need to consider what happened before delivery, what happened during delivery, and what's happening now in the postnatal period. And so we need to consider this whole system-based approach and biopsychosocial factors before, during, and after delivery in order to be able to appropriately guide that person. And then there are factors, and then on top of that, we really need to question what's the priority. And I would have to say that the priority is, well, the person in front of us, the woman in front of us, what are her goals and what are her needs? And then it's also a risk benefit analysis as well, right? And I think we'll delve a little bit more into that. But, we have an athlete, a professional athlete in front of us who at 3 weeks postpartum wants to start running because she, quote unquote, has to. It's her career. But then we have a woman in front of us who says, "Oh no, I'm okay waiting. I just want to know when I can get back to it," and is in no rush. Then we might not have the same types of conversations. So that's just one factor. But then it's also not going to be the same thing for a woman who's had, a vaginal delivery that went quite well, didn't have any tearing, pushed for under an hour, is having a baby. She's lucky enough to have a baby that sleeps quite a bit.
Lucky her.
No issues with breastfeeding. And then another mother who had a difficult delivery, maybe had more trauma to her pelvic floor, is quite fatigued. There are issues right now with energy levels and fatigue. We're not going to be having the same the same conversation. Well, we'll have the same conversation. We're going to be looking at the same things and identifying those factors for each woman, but we're not going to be starting them off probably the same way. I talked about some of the factors more during birth and afterwards, but considering also prenatally, so how active a woman was, how close to her delivery date she kept running or was active. Those are other factors that we're going to have to consider.
Yeah, it's funny that the research led by Dr. Izzy Moore that we did, we published in the British Journal of Sports Medicine, we looked at multidisciplinary biopsychosocial factors influencing return to running. And one of the things we found, which was really empowering, I think, is that women who ran during pregnancy increased their odds of returning to running after pregnancy or successfully returning to running after pregnancy, which makes sense because if you keep conditioned to something, your body's more conditioned to it. So it increased the odds. But like you said, Stephanie, like even two people coming in who on paper on a referral might sound the same. So two women could come in 10 weeks postpartum, really keen to get back to running, but when you delve into it, one woman has no support at home, or maybe she's a single parent even, and and she might have a stressful time of it. She may be having medical issues, like a lot of women, some women get postpartum thyroiditis and thyroid issues after having a baby, whereas another woman could have quite a straightforward delivery. Her experience at home has been really smooth. She's a village of support around her. That makes a difference, because even being able to get a window to do stuff is hard. You need someone looking after a baby really to do that. And two, if you're doing everything and you have very little support at home, you're expending all your energy on day-to-day, everyday tasks. Whereas when I think of my own setup even, it takes both of us, all hands on deck, being very hands-on with the family. And I can't imagine, I know that when my husband's away somewhere, I really notice it, because suddenly I'm trying to do everything and it's so much. So even that, if on those days I don't feel like working out as much, because I'm using a lot more energy during those days just to survive.
Absolutely. And so you're bringing up such a good point, because when we ask questions, to our clients, to the women we're working with, often we're a little bit more in the biological questioning, and we'll talk about the importance of symptoms, what they're feeling, or clinical signs, and how that factors into the clinical decision making for their return to running. But we often skip over a little bit the social aspect. What is your support system? What type of environment are you having at home? Do you have other kids? Are they in daycare? Because sometimes it's going to make a world of a difference if a mom already has one or two other kids at home, versus the mom who has the same number of kids, but they're in daycare. That's going to make quite a bit of a difference. And definitely the support system. I think that's so true. You live it, you have it, the personal experience and the clinical experience. I have mostly the clinical experience, but I really do see the difference. I have a lot of clients actually who, and this is for a specific reason. A lot of my clients, even though I live in Canada, are European. So in Montreal, we have, I don't know if you knew this, but in Montreal, we have a lot of people from France who immigrate to Canada, especially in Montreal, because we're a French-speaking province in Quebec. And so because in France, pelvic health rehabilitation is part of the public system, and we're a little bit behind in Canada when it comes to that. It's mostly in private practice. But so a lot of my clients are actually French. And so they've moved from France. And so a lot of them don't have as much of a support system here, because their friends and family are still back home. And so that's, for me, I would say it's about 50% of the women that I work with who are from overseas. And so that's always a question that I ask. I always ask about, biopsychosocial factors, but definitely that support system, and how we're going to have a strategy for them. I develop strategies with them to be able to figure out, okay, how they might be able to go around, making that work for them to be able to exercise and go running. So yeah, thanks for highlighting that.
Thank you.
So let's see where I'm at with my questions. So you talked about the support system. I'm wondering if we can talk about you touched on the fact that you did that research with Dr. Izimura and a whole research group. And I don't know if you can talk just a little bit more about that study. And I know you were focusing mostly on factors that were facilitators or barriers to returning to running and also returning to prenatal levels of running, if I'm correct.
Yeah.
Would you like to highlight, because I know there are some things that came out of that study that I really like, and that in the female runner course with the running clinic, we really do highlight your research and I talk about those. So I like to hear you talk about it.
Well, do you know, this study was really, it's a really important study to me in the sense that Izzy actually heard us. How I met Izzy was that me and Emma were presenting at a sports medicine conference in Dublin, and it was on our white paper that we were asked to present on, which is even a achievement in itself because it wasn't in a peer-reviewed published journal. But that's how, like, we needed this. There was nothing out there,
Yeah.
so we were speaking about this, and sports medicine audience mainly. When I think I remember it so vividly in my head because it was tiered seating. And all you can see when you're presenting to tiered seating, you see everybody. So all I seen was faces looking at me, and it was mostly white middle-aged men is all I remember. I don't remember picking out females because the crowd was predominantly males. And so to me, I was like, I usually speak to women in pelvic health. This is so intimidating. But we presented and we put out a call for research because we were like, there is no research to really truly guide us. And we need researchers interested in this area. So at that stage, I never envisaged that I was going to be part of the research answer to that. But so I was putting a call out to researchers, and Izzy then contacted me, Emma, and Tom after that, and basically was like, yeah, I'm a researcher, let's do something. So that was a really important, and she was like, I'd like to include you because I think the clinical aspect's really important. So we came on board and we created a survey, and we surveyed 881 women. So it was a really nice sample size. Now it was during COVID, it was the start, COVID had just started. So you always have to take that into account that, you know, in terms of, well, it was at the beginning of it, so I'd like to think people's experiences were true to life. But we carried it out, and I remember in the design of the survey, even the importance of clinicians and academics bridging is so important, because there was questions we were raising, or that was from Izzy's point of view, she's like, well, I don't know, why would that be important? So even things like we were able to pick out the vaginal heaviness, whereas to her, pelvic floor dysfunction was urinary incontinence. We were like, but a lot of women complain of like heaviness down below. So she never would have put that in, and so that was something that came out really interesting. And also it was I think Emma and I kept talking about, but people are so fearful of running, they don't know how to run. So we were able to explore that fear of movement or fear avoidance behaviours, which probably could have been easily missed in such a good sample to gather. So we carried it out, and we found out things like, interesting things for me were that it was a sensation of vaginal heaviness rather than urinary incontinence that stopped women from running. So almost keeping with our stats for the general population, just under a third of women were leaking in our population, which is similar to the general population stats.
Yes.
But they probably were happy to pad up and run, or maybe there was more acceptance of urinary incontinence as this just happens, whereas the sensation of vaginal heaviness was enough to stop women. They probably became a bit fearful about that, actually, and that kind of the unknown. And it also highlighted the importance for any health and fitness professionals out there, or for any moms who are experiencing this, that they don't just consider pelvic floor dysfunction to be urinary incontinence. We have to screen for all the roles of the pelvic floor. So organ support, continence, emptying of the bladder and bowel, and sexual function, they're all roles of the pelvic floor that need to be considered when we're trying to identify if there's any compromise to the function of the pelvic floor. There was things like, I'm trying to think what the key point was. I'm trying to think what, I think women who ran during pregnancy had more likelihood of turning to running afterwards. There was something we picked out, and I can't think of it offhand, to do with the running volume. We found that you might know better if you've read it sooner than me. We found in terms of, let me see if I can actually find it.
I think, and that makes sense. I think if you were running, if I recall, if you were running less prior to delivery, you were more likely to have returned to your running volume before, but I'm not 100% sure.
I've got the infographic here. So
there you go. Now you can
influence in returning to running. So if you had a higher running volume before pregnancy, you were more likely to return afterwards. And there was a really high percentage of people who had lower limb pain, musculoskeletal pain, which was interesting too. So we do need to be, really considering people holistically in the terms of like, I sometimes think the pelvic health physios can get too pelvic health focused, musculoskeletal physios can be musculoskeletal focused, and we can tend to work in our silos, whereas we need to be really working across sectors, working across specialisms, and linking in with people if our own scope limits us, because we have to be really addressing the entire needs of a woman. And essentially, pelvic health and pelvic floor function is musculoskeletal. It's just to a certain area.
Absolutely. And so I think I'm happy you've pointed out the aspects of the paper that I thought were probably the most interesting. And I was wondering if there was probably that link when going back to the vaginal heaviness, because this was a survey, we don't have a confirmation. We can't say, oh, it was a woman who had pelvic organ prolapse. We have no way of identifying that. And I'd like to point out that clinically, and I don't know if you see this as well, but you can have symptoms of vaginal heaviness, and you suspect, you're like, okay, you ask your questions to your clients, and you think that upon evaluation you're going to find possible signs of pelvic organ prolapse, and then you don't. Mm-hmm. So it's not because you have symptoms of vaginal heaviness or symptoms that are often associated with pelvic organ prolapse that you have pelvic organ prolapse, or a high enough degree of pelvic organ prolapse that it's problematic for physical activity. And but what I think is interesting is there was this fear component and this vaginal heaviness that were two limiting factors, so barriers. And so sometimes I wonder if fear is not more of a hindrance to physical activity and movement. And we find this in other conditions. So if we do a parallel with low back pain, I know that some of the research has really highlighted how fear of movement sometimes paralyzes more and inhibits return to sport and return to physical activity and movement, more so than actual pain or actual physical dysfunction. And so I think that maybe for pelvic health, the fear potentially that vaginal heaviness is a sign of pelvic organ prolapse, or the fear that something may appear, because we know that and we haven't gone back to that questioning, but is running bad for the pelvic floor and for pelvic health, and does it cause pelvic organ prolapse and urinary incontinence? We can answer that in a bit, but I think that the idea that it does may prevent women from going back to running, or if they're feeling something, a symptom such as vaginal heaviness, that will probably hinder them or slow them down to return to running. So I don't know if you would agree with me. I don't know if
100%. Yeah, like absolutely what you're saying. I agree with everything. And like, it's funny because like you said there, when we're taking a history and we're with our client, we're already getting an idea or like a hypothesis, a working hypothesis of what we're expecting. And a lot of times we're right. But sometimes we're getting that idea and I'm like, oh yeah, definitely some signs of prolapse. I'm probably going to find a little degree of prolapse. And just for anyone who is listening to this, some degree of organ descent is completely normal postpartum, especially if we've had vaginal deliveries. I've had 4. There's bound to be some descent down there. And I nearly don't want to confirm that because I don't want to give myself a complex over it, because I do think that we can become hypervigilant to the area, and that's why there can be subjectivity in what we're experiencing. So some women who I'm like, definitely signs of a prolapse. And then you go and like that, I'm like, oh, well, okay, there's nothing lying. Let's get you upstanding, because I'm sometimes like, maybe it'll come a bit more obvious now. And no, some women can just be more aware and hypervigilant, maybe because they've heard stuff, or they've heard horror stories, or they've heard myths, or they have a relative who was really troubled with pelvic organ prolapse, and so it's their biggest fear. Other women, I'm not screening and picking up any signs of organ prolapse, and like there could be almost a grade 3 sitting there and they've no idea about it, which is so, I'm like, our bodies are mad and magical in one. But the other thing I find with postpartum women, particularly if breastfeeding, because we do have lower levels of estrogen and we produce a little bit less vaginal lubrication, that can impact what we feel, because usually the vagina, I suppose I was going to say the vagina is usually not open. It doesn't sit open as a compartment when we're not using it. So either if we're not being intimate or unless we're in labor, it's closed. And what that means is that the vagina has lots of folds and kind of tissues. And usually we don't have any awareness of it because it's a moist area and everything just slides by each other. You don't really notice. Whereas when there's a bit of dryness, I do think we get a bit more friction or awareness of that area. And you're like, And then women are like, what's that? Is that a prolapse? There can be so much hypervigilance. And I don't know, Stephanie, if you listened to the second part of the BJSM podcast, we were talking beforehand. I did two podcasts with BJSM, and one of them was one of my past clients, who's also a physio, but it came postpartum and shared her journey for the better of patient understanding. And she presented exactly like that. When I was taking her history, I was like, oh, there's probably a wee bit of prolapse, but let's not worry about that. Don't worry. This is normal. Vaginal deliveries, that's pretty common. But she absolutely had no sign of prolapse on examination, and that was then with getting her standing and really trying to test it functionally. And literally as soon as she heard that, like nearly overnight, her symptoms disappeared because she got a bit of that fear lifted and that hypervigilance lifted, and she got back to doing the sport she wanted. So, it doesn't always mean you have a prolapse if you have that sensation, and that's why it's really worth it. If in doubt, get checked out. And if you do find you have prolapse, it's nothing to be overly alarmed about. The majority of the population, particularly if they've had babies vaginally, do. But we manage this really well, and we live with it really well, and we get back to full function really well.
I did listen to the BJSM podcast, and I think I have that in mind also when discussing the fear. So your parallel, there's a parallel between clinical experience and what that research did say in terms of the symptoms of vaginal heaviness and the fear. I'm conscious of time. We've already been chatting and I still have lots of questions.
Keep going. We got it.
We're gonna move on, but I wanted to really maybe walk through, that was the point of this chat today, but for us to walk through sort of how we follow women. We've touched a bit on it, and I think that maybe you can start or I can start, and then kind of just, I'd love for us to be able to present sort of our approaches, because there's going to be things in common, and then there's going to be things that might differ a little bit, and that's where the interesting parts are when we are a little bit different. And I'd like to present sort of what we teach in the female runner course with the running clinic, because we do have an approach when people take the course. So like I said, it's a 2-day course, and we do provide tools for health and fitness professionals to be able to, based on the knowledge that we do have to date, based on evidence. So it's informed in evidence, but also in the clinical expertise of all the different clinicians and researchers that have created and developed the group. We do offer an algorithm. So it's not a recipe. It's just sort of a step-by-step approach that we're able to use to be able to then provide an individualized approach. So it's an algorithm that allows us to have an individualized approach for the women that we're following or guiding. So I'd like to be able to present that, but I think that we should talk about sort of our approach before I go on and present the tool that we use in the course. So Gráinne, can you walk us through how, what are the key things, if they're not time-based, that you normally use to be able to guide a woman and sort of give her that, I don't like it, but that sort of, okay, you can start, you can test it out, you can go for a first run, sort of walk us through sort of those things that you might look at or assess with them.
Perfect. So like we've already touched on, when someone's coming in, I first of all want to know what their goal or aim of what they're looking to get back to, but I also want to know what their baseline is. So if they've never been a runner and they're suddenly looking to get back to running, that's a different place than someone who's been a seasoned runner and had to take a bit of deconditioning while they were pregnant and going through childbirth, postpartum. I want to know at baseline all the things we've mentioned about their setup, their environment, how they're feeling, everything like that, how the delivery experience went and how they've been feeling since. But then I want to know things like, are you having any symptoms? So the key areas I want to really home in on are abdominal and pelvic floor function, and for the runners, lower limb function, because we know they often experience pain. So I want to know, if they haven't started running yet, just in their day-to-day life, are they experiencing any symptoms of like leaking, heaviness, pressure, difficulty emptying bladder and bowel, any pain with intercourse if they've returned to it? I just want to get a baseline. And then I like to do an objective examination to one, like we've already talked about with prolapse, see if any reported symptoms are matching up with objective signs, and also to demonstrate, because even a lot of women who are no symptoms and they're raring to get back and they think, I have no symptoms, I'm good to go, they likely will have strength and conditioning needs, and it's really important that this is highlighted before. So like, if we think of if you had an injury to your ankle or your knee, you're going to rehabilitate that before you start jumping and doing plyometrics on it. And that's common sense, and that's really everybody, the general public understands that. And you wouldn't even think of jumping on it until you know it's strong enough. Whereas I sometimes think, because pregnancy and childbirth is something that happens every day, people give birth to babies, and it's quite a natural process. And it's something where women just get up and get on with it, and we don't often talk about the symptoms we may experience. So therefore, I think there can be this societal impression that that women, there's no reconditioning needs, and yet we know that women will have to recondition. So I love to do an assessment both in lying and standing. I utilize ultrasound imaging too. I really like that visual and connection that it gives to the patient, and the visual that it gives to me to add on to and to extend the scope of my assessment. And then I like to do reconditioning before we even think about returning to impact. And I like to do a graded approach. So if they've never tried running yet, I want to start to grading them into impact. So there's different ways you can kind of start to grade your exposure to it without just jumping 2 feet in, basically.
Great. And so this is sort of the steps that you normally take just to start, right? So we're not into progression yet. We're really in sort of, and it ties into your other article also that came out, I think, in this past year, but the 6 R's, right? The reframing for return to running. So I can hear that you're talking about the ready phase and the restoring phase and the reconditioning phase when you're talking about starting. So that's a little bit sort of the same approach that I have. I think that right now we've really kind of, one of the take-home messages we're really putting our finger on it right now is that we haven't really talked so much about time. What we're talking about is, what are the needs and the goals of the person that we have in front of us? What is she feeling in her body? So what are her symptoms? And then after that, third, we're doing an objective evaluation. And so that really kind of also, for me, it's almost like we're highlighting sort of the priority. And the priority is really what she needs, what she's feeling, and then what we're assessing. So often I find that as physiotherapists, I don't know if you would agree with me, but we kind of put that objective eval on top, and we go, but we have to consider, I think, those personal and subjective feelings and needs, I think, even beforehand. But at least that's the way I tend
I like to one of the reasons that we put the whole systems paper out was nearly like, I feel like it's a call to action to actually implement a biopsychosocial model of care and not just give it lip service. So oftentimes I think that clinicians actually think, and they mean well, and they think they're doing a biopsychosocial assessment because they may have 1 or 2 week check questions in the subjective assessment, and that kind of ticks that box. But I'm like, the biopsychosocial assessment comes the whole way through the management of that. It doesn't just stop at those questions. Done. I've asked their social circumstances. Done. And then on to what they think the most important part is. It needs to really carry and expand through. And I think the more research we have, the more we're even understanding the importance of that, which is fabulous. And it's so refreshing to hear you think and talk like that as well.
And what you just mentioned is, in terms of, ticking off boxes at the start, I think for the postpartum period, it's even more important, because we know things change. How many times are you, 1 week you've got a mom coming in, oh, things are great, my baby's sleeping, everything's going well. And the next week it's like, baby's not sleeping, mom's not sleeping, the energy levels are just not the same. So, it really also fluctuates. So I think asking those questions at the beginning, but also continuing to ask those same questions, seeing and validating that are things still going well, so getting that information at different time points is definitely needed. We talked about sort of our starting process. I was just wondering, do you have any criteria that would be an absolute no-go? So are there absolute criterias before, if they're not time criteria, so that would be, you absolutely have to have this or not have this to be able to start, even if we're starting progressively and we're just kind of testing out running?
If someone, before they've even started to expose themselves to impact, is having significant urinary incontinence or a significant feeling of heaviness or pressure, I would probably want to get them to a stage where they're not having those significant symptoms when not running, without also getting the balance of not instilling fear, because what you don't want to do is feed the problem with like, oh no, there's something wrong here. Like, but I would want to take them through reconditioning of their pelvic floor and core, but also education about, you know, how we interpret or how we feel sensations of heaviness down below don't always add up. You know, giving them education, showing them their pelvic floor and ultrasound so that they can get, sometimes even just seeing that, they're like, oh my goodness, my pelvic floor moves, or it's working, or, you know, it's sometimes you can see a level of fear just lift from someone automatically. But you should be able to get them asymptomatic before they're doing exertional tasks. Now, that doesn't mean that everyone I get back to running hasn't got any symptoms. Some women are leaking and they're really raring to go. So we just manage the symptoms while we're still doing reconditioning, and that's okay too. Shefali Christopher and Rita Deering put out a really interesting clinical commentary recently in the Journal of Women's Health Physical Therapy, and it was a 4-phase framework for returning to running. So it kind of builds on the work that we started, and for anyone looking kind of more, if anyone's looking more outline guidance or a more outline framework to follow and steps to follow, it's really thorough, and they have contraindications and relative contraindications outlined in it. So things like ongoing lochia, like if someone's still bleeding after having their baby, it's maybe not, you know, an ideal time to start increasing the impact. If significant, they don't talk about, like, some degree of mild symptoms of pelvic floor dysfunction are probably okay, but they're talking about significant symptoms that would be an absolute contraindication. And there's a whole array of other ones. What about you? What would like, my biggest contraindications would be medical unwellness. Like if someone was medically unwell or they were showing signs of sepsis or anything like that, I'm like, this is not the time to be scaling up.
Yeah, I think apart from really medical contraindications, it's almost like when it comes to pelvic health, I feel like it's mostly relative contraindications.
Yes, agree.
And so when it comes, again, it's all that risk benefit analysis. So I think in an ideal world, we're not having any pain, we're not having any urinary incontinence, we're not having any symptoms or signs of pelvic organ prolapse, and everything's going well, and we can just start, even though we're going to start. I think it's not about as much when we start as much as how we start. And so I want to talk about that in a moment. You touched on the progressive, the graded exercises. At the Runners Clinic, we also talk a lot about, I need to translate it in my brain from French to English, but mechanical stress quantification. So that's really one of the principles that we adopt, and also about impact moderating behaviors, because we could have a whole webinar right now on whether running is actually an impact sport. So that there's some questions that I just decided not to include today, because we could really it could just be that, is running really an impact sport? And there's research to suggest actually what's out there is that there are different levels of impact depending on the sport or the activity that you're doing. But when it comes to running, you can run with more or less impact. So that vertical loading rate that occurs when the foot actually strikes the ground, and this is based on a lot of research, because when it comes to running, even though we have less research when it comes to pelvic health, female health, and running, it's growing, and hopefully it's going to grow a lot more, because our superstar Gráinne Donnelly is going to be doing lots of amazing research.
Definitely.
But when it comes to running, there's a huge pool of research. And at the running clinic, there's a lot of different courses. So the female runner course is the course 1.9, but there are a lot of, so we've got the 1.0, 1.1, 1.2,
Wow.
lots of courses. And 1.0 is really that course, that foundational courses on injury prevention. So anyone interested in learning more about how globally you can prevent injuries to the body with running, because that's really the first step, right? We want people running because it's good for them. Exercising is good.
Absolutely.
But we don't want injuries. Injuries are not fun. So one of the main principles is this mechanical stress quantification. So most injuries in general in running and in sports are due to an improper quantification of the mechanical stress on the body. And you mentioned how the pelvic floor and the pelvic region is really MSK, right? It's musculoskeletal. It's just that it's this special area of the body that includes a lot of different functions, that's got a lot of primary functions, and is impacted a lot by pregnancy and by childbirth. And so we're bringing this particular attention to that part of the body, but we can definitely apply some of the knowledge that we have when it comes to running and its effects on lower limb, on the pelvis, on low back. And so we know from research that vertical loading rate, which is really a way of measuring impact when we run, can be changed and altered depending on certain factors. So how we run, and we're not talking about sort of those little changes that we might do, inverting a little bit less the foot, or aligning our knee a little bit more, or the way our arms are moving necessarily. We're talking more about, for example, the cadence. So the number of steps that we take in a minute. So we're talking about running, with more vertical displacement. We're talking about more or less a vertical displacement. We're talking about running light versus running heavy. So if we're hearing every impact, every strike of the foot on the ground, we know that there's a higher impact going through the lower limb all the way up the body. If we're running with a higher cadence, which means more steps per minute than a lower cadence, if I've got more steps in 1 minute, that means I'm doing smaller steps versus longer steps that are automatically going to have a greater impact when my foot hits the ground. So those are just some of the examples of impact moderating behaviors. So things we can actually change that will have a different an impact. Will have an impact on the impact that running has on our body. And so those are the types of principles that we can apply when we talk about returning to sport and injury prevention, even if we're talking about injury prevention to the pelvic floor and the pelvis. And these are the types of things that we teach in the running clinics course, or the female running course. We go over those basic principles in the course. But so that was just my tidbit on the fact that it's not so much about when we start running, but it's also how we start running. And when it comes to symptoms, I think you mentioned it. You mentioned, we're more concerned about significant or important levels of symptoms. But if someone, so for example, if I have one of my clients, and this happens often, oh yeah, it's true. If I sneeze and my bladder's full and I'm holding my child and I didn't get a chance to go to the bathroom for the past 4 hours, I might leak. If this is the one symptom that my client might be presenting with, I don't think that would be a reason that would be good enough or valid to stop her from returning to running. So it really depends. We have to look at the severity of the symptoms. What we absolutely don't want when we get back to running is we don't want someone who was having very mild symptoms in her daily life, was having no symptoms in her daily life, and starts running again. And now symptoms are appearing while running, after running. She's having an aggravation of her symptoms, or new symptoms appearing. Then we're going to be concerned. And then we're going to go back to looking at, well, are we properly quantifying mechanical stress on her body? And sometimes that involves not just looking at what we decided to choose as a running program. And we can talk a little bit about those progressive running programs, but it might have to do more with looking at what's going on in her life. So in that day or that she went running, did she also do the groceries? Was out for 3 hours, went to pick up the kids from daycare, from school, was cooking, all day long, and then went out for her, 10-minute run. At that point, we have to, things are relative. We have to look what happened all day long, and is the running portion of her day really the portion to blame for the symptoms? So that's what we discuss in the course when we're looking at stress quantification.
I was going to say to complement that, because some of my runners, I would find that they only find that their symptoms may come on if they run in the evening. So if they do a run earlier in the day, they don't have symptoms. So that's the time that, for now, this is the window to go running and enjoy it, and not have to think about things and worry about things while we're reconditioning. And then we're going to gradually expose that run to later in the day, and hopefully get her to the stage where she can be asymptomatic whenever she decides to go. But it's meeting people where that. And what is also key to highlight is that conservative rehabilitation will help everyone to some degree, but it may not resolve symptoms for everybody. And some women, conservative rehabilitation may be all they ever want to do. So we have to be comfortable with the fact that for some women, they may be symptomatic with running, but it's about getting the quality of life and something that they can manage so that it's not impacting and, spilling out into the rest of the day when they're not running, as you say. As long as their symptoms don't progress in other times, if they have a wee leak while they're running, or they know that they get to a certain running volume and they always leak at that point, there's something being okay. We have to be okay with that if the patient's okay with that. The other thing is that for some women, it's not a muscle strength thing. They could have really good muscle strength and conditioning, but it's a connective tissue issue just as a result of childbirth. And so we manage that with the likes of intravaginal devices or pessaries if a woman wants. Some women may not want that, and so they're happy with the leak because they understand why they're having it. So it's all about meeting the individual where they're at.
Exactly. So I completely agree with you. And I have examples of that. I had an ultra runner. I had a client who was an ultra runner and was changing, I think over the course of a 100K race, was changing her shorts and her underwear about 10 times. And well, she was kind of a special case because she had been doing this for years and then decided it was time to come and see someone. And it was kind of this miraculous thing because she said, I just thought it might be a good thing to come and see you, but it's okay if it doesn't get fixed. I just like it for it to be less, And but she was okay with running and having urinary incontinence. She just thought maybe it'd be nice if it was a little bit less, her degree of tolerance was extremely high to the urinary incontinence. So I figured, okay, if I can just teach her a few things. I mean, she's literally telling me she's okay with it, but heard that pelvic health physio could help. And so if we can get a little bit better, she came back to see me 4 weeks later and had no more symptoms. Just from that getting her in contact with the pelvic floor, I couldn't believe it. So I mean, this is rare. This is not like
that's life changing though. That's like absolute life changing, and that totally changes even her ultra running experience. Even though she was comfortable to continue on, that wasn't going to stop her doing her ultra running, but she can probably do her ultra running better or enjoy it more. You know what I mean?
Absolutely. So I don't know. I think she became quite the advocate for pelvic health.
Love that. Yeah.
Yeah. But I mean, anyone watching this right now, this was a special case in the sense that it's very rarely a quick fix, just the way that happened, But I was more affected by the symptoms that she was having, I think, than her, in the sense that she was slightly bothered by them. And for someone else, having just a small leak, because it's really about the level of tolerance. It goes back to the fact that we have to meet the person where they're at, like you're saying. We probably only have a few minutes left because I know you've got some kids to pick up soon.
I do. And what I want to highlight was, because we haven't answered it yet, your really good question about whether running's bad for the pelvic floor. Well, our colleagues who have paved the way in a lot of the research, Carrie Bow and did she do it with Ingrid Nygaard, did a nice narrative review on whether physical activity is good or bad for the pelvic floor. And really, we don't have any conclusive research to say that it's bad for the pelvic floor, because we just don't know that. And to be honest, the more we think about things, like physical activity is the best medicine approach for any health condition I can ever think of. Any health condition we think of, physical activity is a positive influence on it. And I think that we have to really understand the benefits of it. And actually, sometimes when we get women running, as long as we get them, if they continue running, say like the ultra runner, and are wet or symptomatic, but they do engage in pelvic health rehabilitation, often those two components, by running side by side, like focused training alongside exposure to impact, actually complement each other quite well, because it's all to do with the load tolerance of the tissues, and it's exposing them to load so that they do their natural response automatically. Because there's one thing being able to consciously contract the pelvic floor, but you don't sit and run and think about every single step. Your pelvic floor just performs naturally. Exactly. Or should, hopefully, and that's what we need to give it exposure to. So when we're talking about graded exposure, things that I like to do are even things like, I love step up sort of training, like step ups, like just stepping up to a step, like an aerobic step up thing. I love doing that because there's less impact on the way up, and you can start getting people doing components of things that look like running. Or the other one I like to do is skipping with a skipping rope, because it's jumping, it's impact. or leaning against a wall with their hands and doing running drills, because they're starting to, it limits them, it changes things, but they can offload a little bit. What do you like doing?
Oh my goodness, in terms of exercises.
Do you have time?
In terms of the time that we have, I think we'd probably need another webinar. The ones that you said are very interesting. I think it's always what I tend to do. I don't have a recipe again for exercises.
Yeah.
I have normally what I do is I go through some exercise and see where the person's at, you know. So sometimes are we having to start really lying flat on the ground? I think that one principle you need to adopt is really try to mimic running. If your goal is to run,
Yes.
you need to have your exercises when you're going into functional exercise. We talked about training the pelvic floor. Yes, we need muscle hypertrophy, endurance, capacity to contract rapidly, coordination with the rest of the core muscles, and then we need graded functional exercises that are specific to running. We know about specificity, and we know that we need to be specific to running. So then we try to mimic those movements and what the body needs to run, but we can start lying down. We can be side lying. We can be on all fours. We can be, you know, at an incline. If we're not doing, you know, completely horizontal, we can be at an incline. We can be against a wall. We can be, single leg exercises. You can be impact plyometric exercises. So it's all about grading the exercises. But I think what I tend to do is evaluate and see where we're at. If I've got someone who's got very little pelvic control, lying down or in side lying or on all fours, we might not be doing, you know, single leg exercises, plyometrics just yet. We might be starting there. But I'd like to mention that I really like what you pointed out, that there is no proof that running, I want to say this, there is no proof that running is bad for the pelvic floor. It is about right now, but we're still, there's ongoing research. We want to know more, but there is no proof that it causes urinary incontinence or pelvic organ prolapse. It will highlight or shed light onto some of the problems, some of the physiological potential issues in the pelvic floor with running. But that's the same as sneezing, coughing, lifting, standing for a long period of time. Those activities will shed light onto a physiological dysfunction sometimes, and will basically inform us and guide us to be able to what we need to target. And so we can be training, we can be working on our pelvic floor muscles, on our core muscles, on our functional exercises while running. And we're having some research to date that is even showing us that running can be a form of training for the pelvic floor, and that makes sense. Our pelvic floor and our core muscles are recruited involuntarily in an anticipatory manner every single time we've got a foot strike. I don't want to say heel strike because not everybody runs on their heel. Foot strike. And so it can actually be a method of training. And again, it really depends on the person. We need to have a component of subjective and objective evaluation, and then there might be different groups of people for whom it might be appropriate right now to use running as a method of training, and for other people so really there are some people we might have to motivate and get to running faster because they're having a lot of fear, but really they're okay to run. And then we have other people we might need to slow down because maybe right now is not the right time yet for them. So I mean, again, it goes back to that individualized approach, really. I lost my train of thought. I think that what I'm going to have to do is the algorithm for the course. Because I'm going to have to let you go soon, I'm going to go through that algorithm and talk a little bit more about the female runner course, but sort of in a different section. So I'll be able to post that in a different video so that Gráinne can go pick up her kids. But I'd like us to just, end off maybe on some key take-home messages or anything else that you wanted to add to our conversation.
I want to add that in the white paper we originally put out, we had some load and impact tests, which were more hypothesized based on, because again, even when we looked at mainstream return to injury, there was no set drills or exercise that we go to. So we took the best of what our knowledge was, but we were very clear that these are not set in stone and we don't have robust guidance around them. Now, clinicians report that they find them useful because it gives them some ideas of, as clinicians often like ideas. It's not that they like prescription, but they like ideas of go-to things that they can do. So clinicians were liking them for the ability to maybe give them some tools to expose those symptoms you talked about, to go, well, oh, okay, actually there's some degree of strength and conditioning we need to work on, or there's something else we need to work on. But interestingly, because I see Shefali and Rita have some kind of tasks to kind of meet, or low tolerance tests to meet too. But Izzy Moore has a PhD student who's researching some of these exposure tests and things. So it'll be really interesting as the research develops to say whether X, Y, and Z exercises were useful for screening, or whether they added nothing or they didn't match up. So that's what we need to do. But putting them out there in the way we did give researchers a reason to want to go, well, do these actually tell us anything, or do they not? So I'm excited to see that, regardless of the outcome, because it just helps us develop and inform. But trying to think other key things. Oh, I definitely think we're going to have to do a part 2 at some stage, because we could really get into the nitty gritty of it. But the key things that we've highlighted today are that it's definitely biopsychosocial, and you have to look at that person in front of you and find out not just about their time scale or physical experience, but their environment, their social support, how they feel within themselves. We also need to then think of the strength and conditioning needs for core, pelvic floor, lower limbs. We have to remember that if people have deconditioned, runners need their calf muscles, their quads, their hands, their glutes. These are key muscles in running. So we need to be thinking about strength and conditioning all of these in preparation for return to impact. And yeah, there's things that we can do at the time, like as you say, even modifying whether it's cadence, or whether you just think of a runner just thinks of slowing down and exerting themselves less, that could be the difference from leaking to not leaking. So you get them at a pace that works for them. Asymptomatic, maybe nudging into that kind of zone of, they might be kind of challenging themselves a bit here, but over time that hopefully progresses. And that's why it's good to keep them running in a way, because you get objective markers to work on and improve, whether it becomes running volume, whether it's they can change their cadence, they can change their exertion, they can change their pace, and you can find out whether they are able to do that, and find that they can go longer asymptomatic or not. And adjuncts to treatment. So one of the exciting things is I'm writing up, it's only a small scale feasibility study, so, and it was underpowered, but I expected it to be, but hopefully it'll stimulate more research, and I'm hoping to go on and do a bit more research with it. But I was looking at compression garments to see if there's any mechanical impact on the pelvic floor, because a lot of my clients find that when they wear targeted compression garments for the pelvic floor, that they feel that they leak less, or they have less pressure down below. And we didn't know whether this is placebo, because it's just to feel better, so it reduced their fear, or whether there's actually a mechanical response. So what I found in my research is that there is some women are getting a change in their bladder neck height, but it's not consistently happening across the group. Now, I had a normative sample, so it'd be really interesting to home in on some specific populations. But I think this is a really exciting area of research, and I'm looking forward to seeing what that brings. Because again, if we have some women who are never going to be fully asymptomatic, adjuncts to rehab are really useful, whether that's an intervaginal device, whether that's a compression garments that do have some sort of evidence behind them, whether it's, there's so much that we can do to support women. In the same way as if we think of men playing football or doing anything, they will use adjuncts depending on what their needs are. So some wear strapping, some wear certain types of sportswear, some, you know what I mean? They may be braces. It depends.
Absolutely, because really that's what our goal, right? We want to get people moving. We want people to get running, because it's just good. It's good for physical health. It's good for mental health. So really that's our goal. So we don't want to over limit. We're just trying to find the best strategies to be able to get back to it or start it in a safe and effective manner that's going to encourage people to keep with it as well. Because if you're getting back to something not in the quote unquote proper manner, and you're getting injured, then that's actually not going to motivate you. That's going to tell you. How often do you hear, oh no, I can't run, I have bad knees, oh no, I've had kids, oh no, there's just so many reasons that people think, and we didn't touch on this today, but often these beliefs and ideas come from therapists.
Oh, completely. And people take words that a therapist says as, well, they said it, so it must be. And one of my things is that not everyone is a runner, and not everyone enjoys running, and that's okay. So it has to be, you only get people back to running who want to run and enjoy it. It's not what I want people back to, it's what they want to get back to. But there's part of me that wants women to be able to run no matter what, even if they enjoy it as recreation, because it's our survival method. Like if you're in danger, you need to be able to run. And so I don't want women going, oh, but I can't run because I've got bad knees or bad pelvic floor. I want them going, run.
Yeah.
Run.
Absolutely. Like we were meant to run, like, you know, and we could have a talk on that, but I mean, but yeah, we understand what we're saying. And I wanted to just quickly go back to you talked about also, we talked about conditioning, we talked about strength training, we talked about, and the importance, like we didn't get into today the progression. I think I agree with you that we need a part 2. We talked mostly about how to start or how to get back to it in the beginning, but the body adapts. When we have injury, that's a sign of maladaptation, but the body adapts when it's progressed. So one of the key things that I tend to tell my clients, especially when we're starting, when I'm educating them about stress, mechanical stress quantification, the impact moderating behaviors, monitoring their symptoms, understanding what those symptoms mean, reassuring them, empowering them, reducing fear. I'm also teaching them that to be able to progress, they need to do a little bit more often and progressively. So to be able to run, and one of the principles of preventing injuries for running is actually going a little bit more often than not and progressively. So it's better, for example, to run 3 to 4 times a week, a little bit progressively, perhaps in the beginning with a walk run intervals, interval program, than it is to go running half an hour once every week or once every 2 weeks. You might not get injured. It's possible that nothing's going to happen, but we do know that predisposes more to injury than doing a little bit often and progressively. So that's one of the things, you know, that I want to highlight, is that the body needs that progression in order to be able to adapt. And we touched on it when we talked about conditioning and strength training and all of that. So
I love that, because one of my pet peeves with pelvic floor training is that I think there's nearly a pandemic of people thinking that Kegels are just doing wee squeezes that I can do anytime when talking, and so they're never getting that overload. And like, if you think of any other area in the body, if you're anyone who's doing personal training, if you've got a personal trainer, you're not going to be doing a weight exercise and you're going to go, oh, that's tired, so I'll stop now. They're going to be like, do some more. You know what I mean? Because you're going to get into that fatigue zone. And I think people forget that the pelvic floor really needs to be trained with the same principles, and more so than other areas, because the pelvic floor doesn't get to offload in the same way as if you had a injury somewhere else in the body. If I had a lower limb injury, I'd be able to offload it if need be. You could be non-weight bearing, you could be partial weight bearing, but your pelvic floor has functions to do regardless of whatever injury you have. You're going to be emptying your bowels, you're going to be controlling continence, or not controlling it, but trying to control it. So it's such a complex area, and I think we need to give it more focus in terms of sports medicine, like that it's the same as trying to train any other area of the body. But then when it's coming, that's why that exposure to running is really important too, because you have to expose it to those situations that demand of it so that it gets challenged.
Exactly. And I think there might be people watching this who are this is going to completely shift their paradigms and their thought process, because 5 years ago, 10 years ago, I may have had this, and this is a product of what I was taught. I may have had the same conversation with you and would have said, oh no, we need to offload.
Oh, completely. And I would agree
we need to load.
I've grown, but that's the beauty of research, and anyone who's in doing sort of like evidence-based practice, whether you're a clinician or you're a clinical academic or academic, you have to be ready to evolve, because the more we investigate, the more we understand, and that has to change our beliefs and what we understand about it. We can never be static, because it's always evolving, and it's exciting, and I just love it. I can't wait to see what happens the next time we talk, but we should do another one of these. And we knew this would happen. We knew we'd talk too much.
We had probably about 4 times more, you know, anyways, we knew this was
I even created slides. We can do that. We can do that the next day.
We could have a 24-hour marathon probably, and we'd be able to talk.
It should just be an ongoing station. This should be like a show that we do every so often.
24 hours a day. So what we're going to do, I think, is in the description for the video, I'm going to add links to, we're going to have links to your work, some of the articles, all the things that are open access, and maybe the references for those that aren't. We'll link up the female runner course from the running clinic, the athletic female course.
Yeah,
we
yeah,
do that.
yeah.
We'll put that in the description as well. Different websites, so that anyone who just wants a little bit more info, we'll put some different websites to just add some resources to this talk today. And I think we'll need a follow-up talk, Gráinne and I, and I'll do a follow-up video to be able to explain a little bit and present the algorithm that we use in the course.
That'd be so cool. And if anyone has questions of things that they were dying for us to delve into, put them in the comments or whatever, so that we can then plan that in the next time we talk.
Yes.
Because we want it to be interactive. We want people we want to know what your thoughts are. But this has been so exciting. I'm so delighted to be able to catch up with you. It's been long overdue, and let's do this again soon. And I am actually going to, I'm going to have to go and collect myself. All right, okay? Mom life. Bye. Thank you. See you later.
See you later.